Okay, thank you very much. I'll introduce myself. Um, Thanks for coming this week. We have a substitute grand rounds today, which is me. In part of our ongoing efforts to engage fully the cancer research community at the University of Florida, we have we'd like to present to you our progress towards NCI designation and to tell you more about what we're trying to do on behalf, first of all, of our patients and our citizens, and secondly, to help you help them through engaging in more productive research, collaborations, and enterprises. So that's what the Cancer Center is about. And I'm delighted also in the audience here, Deputy Director John Wingard, Associate Director for Administration Bob Houlihan is here as well, and we can answer any of your questions offline as well. So our mission, of course, is to try to work with cancer at every stage, at the prevention, detection stage, treatment, try to ultimately cure cancer or try to contribute towards that, alleviate symptom burden as well. In our individual patients and clinics, and try to think at our population citizens as a whole, and we're doing this throughout the spectrum of cancer research, from basic discovery, prevention, screening, all kinds of things we will try to innovate. At the same time, we have a major mission is to engage our population in our region and to also think about that research in the context of our population, also at the same time training our next wave of cancer research investigators across the spectrum. So these are our charges. NCI designated centers, which we would like to become the 71st. Maybe if our friends in Miami get to become the 71st, we might be the 72nd cancer center in the United States. They are enterprises that combine studies in basic research, translational research, clinical research, and population research to try to move our fields forward. Now, we've taken our rubric of how we'll explain what the Cancer Center is trying to do through a recent presentation from Norm Sharpless, the new NCI director. Not so new now, in office for about a year. In a recent presentation, he talked about four pillars of the NCI Cancer Center mission. Basic science, and these are some ways we're fulfilling it. We'll go into these in more detail. Basic science, our strong cancer focus and positive funding trajectory, clinical trials and clinical research. So we'll talk about how we're doing that. Population science and big data, which is, we have a number of initiatives here, and workforce development. These are the four pillars that the National Cancer Institute is working on, and I think we're aligned to address these four pillars. Now, the other thing to say is we're sitting here in Communicore in the Health Sciences Center, but one of our goals and one of the things I thought was so attractive about the University of Florida as a locus for a cancer research center is our unique position in a land-grant university with 16 colleges, hundreds of departments, 50,000 students. What can we do to leverage all that? Towards that effect, not only do we have all 6 health science center colleges involved, we have another 5 colleges for a total of 11 out of 16 colleges of the University of Florida are included in our Cancer Center support application. So truly this would be a University of Florida-wide, with the emblematic clock tower, of course, wide enterprise. Ranging, not only our health science things, but liberal arts and sciences, journalism, communication, agriculture, engineering, all these various colleges involved as well in different ways. Now, our state of the union here is about where are we as a cancer research center? Do we really have enough research here? Well, University of Florida as a whole is over $800 million in research grants and contracts. The goal of the president and the trustees is to get that to $1 billion, and we'd like to be an important part of that. We think across the campus, cancer relevant, we've looked at these grants, well vetted. we're getting close to $30 million a year of direct expenditures in cancer research on this campus, of which about $10 million is NCI. Sorry, pardon me. 10 million is NCI. We have other peer-reviewed projects, other NIH. These might be American Cancer Society, Leukemia Lymphoma Society, other NIH grants. For example, brain tumors are often covered under the Neurologic and Communicable Disease and Stroke Institute, though the title of the grant is brain cancer. You know, so we have cancer-relevant grants that are not necessarily NCI funded, but highly cancer-relevant. And even these non-peer-reviewed projects, they're peer-reviewed. Most of these things are from highly competitive foundations. It's just not on a special list that the NCI considers their peer-reviewed. But we think they're pretty tough to get. So these nearly $30 million a year direct costs. This is a graph we're all very proud of. This is thanks to your work all together. Over the past 5 years, our cancer-relevant funding, strictly defined as peer-reviewed, so it's less than that 30 million, it's more like 24 million because we're taking out those other, quote, non-peer-reviewed, has gone from 11 million to nearly 24 million. So we've doubled this in 5 years. How have we done that? We've done that through recruitment, both engaging people, internal recruitment, and helping them get into the cancer research field, and external recruitment to the effect of over 30 new faculty members have been recruited with various departments and schools to Cancer Center membership. We also have a number of pilot grants that many of you have competed for. Our funding rate for those is better than NIH. It's about 25 to 30%. So the pilot grants are one way. And also we've been really giving money to people who've just missed the pay line for have a really cancer-relevant grant. We're giving you money to help you get that resubmission so you get to the next step. That's the ways this funding has built. And that's the kind of things that our peer reviewers who would review us in about a year would like to see. Where are we in terms of other centers? We're actually in pretty good shape in terms of grant dollars awarded here, which so there's a difference. When you go to the NIH reporter, we live and die by this NIH reporter looking at funding levels. It only says what's assigned to your institution. If you have a grant for $1 million, you give $500,000 to another institution. It doesn't read that. It just reads what was assigned to you. It's a little different than our direct expenditure things because we only, well, it's a different thing. But if you take a look at what cancer research does the institution own? Well, over here at the far left, you got $90 million a year from Dana-Farber and about $60 million from MD Anderson. Not comparable. What's more comparable to us is a matrix cancer center across many different departments and colleges. And if we take a look at here, we have University of Florida at $16 million. Right above us is University of Southern California. Been an NCI designated center since 1973. So we're doing pretty well compared to them in terms of assigned grants. We actually have more NCI grants assigned here than Moffitt in Florida, which is the only NCI designated center. And we have, at last count, much more than University of Miami, our friends down there. So we're really doing quite well. We're sort of, in the median. We'd like to get over to here. That's going to take a lot more building, and it's going to have to move in concert with the overall institution plan to build research here. We also see that the NCI designated centers are clustered in the Northeast, in the South, in the California, and we have very few here in the southeastern United States. In fact, the nearest NCI designated center is Moffitt, 122 miles away. Then we have these others that are several hundred miles away. So there's really, when we show this to our friends at the National Cancer Institute Office of Cancer Centers, they're actually quite taken with this. It's really geographically distinct from Moffitt. Miami's down here. I think if you have 3 cancer centers in the state here, here, and here, you pretty well have the state covered. This area, I think, is within Alabama, particularly their catchment area, but we could help them as well in the future. Okay, so the Cancer Center, as a total, we have currently 259 members. These are members of all people who have shown an interest in cancer research, and we allot these across 11 colleges and 63 departments, and we have 3 programs: Mechanisms of Oncogenesis, our basic science program, the Population Science program, and our Cancer Therapeutics and Host Response. And so, if you should be in one of these programs as faculty. Trainees are on our mailing list as well. If you'd like to get people in your lab or your research groups that need to get more access to our communications, please let us know, and we will be sure people get on the mailing list. And these are the programs. All the programs have recently had research retreats to try to further engage people in research, and have had a number of other activities, program meetings on a regular basis as well, to try to stimulate this interactions. And the idea of organizing into programs is not to put people into a little box, but to try to stimulate some topically related research in the same group, but so to try to stimulate discussion and collaboration. One of the main things we're charged to by the NCI Cancer Center movement is to stimulate collaboration, with a great belief that bringing people with varying expertises, various expertises, they all have great expertise, but they all have different expertise together, we can have a more effective research output. So we've had a number of strategic recruits into our program with all these different schools across this, a great deal of collaboration across different colleges, and we've had 7 of the 11 UFHCC participating colleges we've co-recruited with. And so that's one thing we try to do as a matrix cancer center. We're not like the MD Anderson, where everyone works for MD Anderson. We're not like Dana-Farber. We are a matrix center. We work with the colleges and departments and work together to recruit faculty that will fulfill an academic or clinical or teaching mission of the college and department, at the same time can contribute to the cancer research or education enterprise. And this just shows we've also had an emphasis on early stage investigators, and we've recruited people, early clinical investigators, early laboratory-based, early population, dry bench-based, and so we've had about 15 of these. A lot of them have been in the translational program, and this might represent both clinical investigators as well as laboratory-based, and a number of others, the other programs. So about half of our recruits over the past 4 years or so have been early stage investigators. That's actually a metric that we're going to be measured on by the National Cancer Institute movement, because it's not supposed to be a cancer research program that takes a bunch of very well-established people, lets them play in the sandbox. It's about how we can bring new people up and foster their careers as well. So now I'd like to go through each one of the pillars in more detail. The basic science, we have 2 programs that would be in basic and laboratory-based translational science. That would be Mechanisms of Oncogenesis. And this program has over $7 million per year of NIH, NCI, and other peer-reviewed funding, and has 34. For the purposes, we have a lot of members. For the purposes of grantsmanship, there's a subset of members that we put into the grant. Those are the people who have the most current funding. That we love everyone, believe me, but we have a grantsmanship kind of issue that we own. Some subset of the membership is represented in the core grant. For all intents and purposes, anyone who's a member is a member. We don't make distinctions. But for the grantsmanship purposes, we have 34 members, a number of cancer-relevant publications, and a good number of intra-programmatic and interprogrammatic publications. That's a healthy percentage of 1/4 of publications being collaborative in nature. What is that program about? We have themes such as epigenetics and aberrant gene expression. This just shows, the nucleosome and DNA and epigenetic factors. One other focus has been DNA tumor virology and RNA tumor virology, and this just shows the work. One of our centerpieces of that program is a program project led by Dr. Rennie, our associate director for basic research, in which he and Scott Tibbetts and a collaborator at Louisiana State studied microRNAs encoded by viruses that hijack cellular machinery to encourage viral replication, and also is a requirement before a virus-induced oncogenesis. Same time, microRNAs from the host impact on the virus. So there's a whole current of this program interested in aberrant RNA metabolism and RNA network interactions in cancer, long non-coding RNAs, short microRNAs, and the like. So that's just one vignette, one example. Our goal in our core grant is to present several of these collaborative vignettes and indicate what kind of impact these findings have to the cancer research community, either as a fundamental knowledge, a lead towards a experimental therapeutic, or a clinical trial. In the cancer therapeutics and host response, again, nearly $7 million per year. This is considered quite good. We have more projects here. Some of these projects may be peer-reviewed funded clinical research trials. There's just more activity in this program. There are more publications, and a good, healthy number of these are collaborative publications. There's several foci here, I would say, cancer therapeutics and the inflammatory responses and the microbiome and how this might impact on cancer etiology and therapeutics, and a small molecule therapeutics group, which is really growing. We've had a lot of co-recruits with pharmacy, particularly in medicinal chemistry, like Dr. Lee here in the audience. One thing, though, is of great interest is in the entire field with the advent of effective immunotherapy is how to augment those immunotherapeutic responses. And one thing we're very interested in is Dr. Sayur's work. Dr. Elias Sayur is a pediatric oncologist, MD, PhD from Duke, studied with Dr. Mitchell, came down here to set up his own program. And he's got a program where he takes RNA from a brain tumor patient, can do it from any type of tumor, and tries to put that RNA into dendritic cells to present. The RNA is taken up, it's translated, proteins are made on the dendritic cells that are exposed to the immune system, and tries to make the immune system more reactive. For example, brain tumors are not that immunoreactive because there's not lymph nodes in your brain, so you can't really educate the tumor in your brain, so you take the tumor material out of the brain, try to create a vaccine to educate the peripheral lymphoid system to react to the tumor, but those lymphocytes can't traffic into the brain. So the idea is to make a more effective brain tumor vaccine. So he's been doing this and showing that these nanoparticles coated with RNA can efficiently get into dendritic cells and create good infiltration of T cells into a site, indicating that there's some education going on. And in a vaccine trial, you can find that in mouse model, this can extend life of a brain tumor model in mice. Now, working with Dr. Milner, they're now doing a clinical trial in dogs, which can be a run-up to the IND-enabling studies. Actually, what we're doing is we're going to actually assist Dr. Sayur in doing IND, meaning investigational new drug, enabling toxicology studies to enable him to go to the FDA and actually put this into human beings. Starting with his own basic science work, translational work in mice, through dogs, to people, this is kind of the home run that our site visitors and the NCI would love to see. So we're heavily supporting this, and it's peer review funded as well. Okay, moving on here, the other thing we've tried to do for the basic and translational research is to assist the very unique ICBR. You know, most places don't have this ICBR that we have, this state-funded institute for getting great technologists here. What we have worked with them to augment flow cytometry. We have There's now a 27 color, 32 color fax scanner, right? And we have several fax scanners that we've helped them obtain. We'll work with them to get the Illumina 3000 sequencer, as well as now the Chromium 10X, and there's a symposium on single cell technologies from Chromium people this afternoon. Many of you might be attending. The other thing we've done is Dr. Jian Li is in the audience. She's the director of our Biostatistics and Quantitative Science shared resource, and she's available, and her associates, to offer experimental design of your basic or clinical study, what statistics, what kind of rigor, reproducibility you have to have in order to have a successful grant and successful paper. There's been a lot of concern about reproducibility in the field. We're meeting the challenge with the biostatistics and shared sciences. Going forward, we're working with Dr. Volpe and so this just shows some of our investments here, okay? And here's Dr. Lee, and we're thinking about biostatistics. We're thinking about typical biostatistics support. She just completed the Biostatistics 101 class. We had 44 students who obtained their certificate that they've attended this course. We're going to have a Bioinformatics 101 course. We are working to try to work in the field of health informatics along with the population sciences group and other computational biology support. So developing cores include working with the ICBR and Chris Volpe to try to get a gene editing core up and going here for those folks who have not yet mastered this technology and want to get into it. Working with MedChem, Dr. Hendrik Leusch and Ranjula Ratanyake, we are developing a molecular screening core to further have a finite number of projects where you have a target and you want to screen for a drug or for a phenotype using their high content imaging or high throughput screening capacities. And lastly, in cancer informatics with Dr. Jian Bang, they're developing mobile and e-health technologies that may be used by clinical investigators and population science investigators. Okay, so where do we need to go? We're going to put all this down. We did all this stuff. We put it into our grant, and then we say, where do we go from here? We think we need to further develop investigators, external or internal recruitment in DNA damage and repair, more RNA biology. I'd be interested in more studies of cancer metabolism, the differences between normal and malignant cells. In CTHR, we think these are some of the topics we'd like to augment. And there was just a kickoff meeting for a brain tumor specialized program of research, so-called SPORE. Most NCI designated cancer centers have these multi-PI specialized program grants. And the first one we think we have a chance to develop would be in brain tumors. And I think we also need to further develop tumor research for tumors relevant to our catchment area, including these tumors. So to summarize this, we have a strong research base. We've brought in over 20 new lab investigators, doubled our cancer-relevant funding. We have 3 programs aligned with the NCI guidelines where we believe they're going to demonstrate collaborative and cross-cutting interactions. And we've augmented our shared resources as well to try to help the basic and translational cancer research base. The next thing to discuss, the next pillar, is the clinical trials. And major milestone here is that any interventional cancer-focused trial has to be reviewed by the Scientific Review and Monitoring Committee of the Cancer Center before it goes to the IRB. Dr. Norden, the VP of Research, has signed off on this. This is a requirement for NCI-designated cancer centers. The other thing we work with is working with Allison Ivey, Director of the Cancer Center Clinical Trials Office, and Brian Severe, who used to head that office, now heads the campus-wide office. We have generally adopted Encore, a clinical trials electronic management system, which has rapidly become industry standard. And what we do is the Cancer Center employs regulatory affairs and clinical research assistants, but also works with other departments who have had for various reasons have their own staff, but all the staff have to take the same training, are held to the same integrity standards to be sure that the clinical research data is in good shape. So these are things that we're doing here. Where are we going with clinical trial activity? The NIH, the NCI, defines a clinical trial as a prospective intervention done to a patient, not a retrospective look back, not comparison of things that you did in the past for the past 5 years versus 5 years behind that. It'd be something you're doing prospectively. That intervention could be to treat a tumor, to treat a symptom, to do a new diagnostic test, to do a new preventive measure, but it's relevant to cancer and it's an intervention. By that definition, last year we had a total of about 300 accruals, and we're on track. We have 435 at the end of 10 months. We're on track to have 600 accruals this year, nearly doubling our accruals from last year. In terms of which one of those are tumor treatment, we had about 169 tumor treatments last year. We're also going to double that as well. So we've doubled the clinical research engagement here to a pretty healthy 600 persons per year. There used to be a mathematical calculation that Cancer Center site visitors used to do. How many new patients do we see here at UF per year? It's about 3,000, 3,200. And so you take 600 divided by 3,200, it's a pretty good number. It's not a really fair calculation, and the NCI discourages that what percentage of your patients are on clinical trials. It's not supposed to be review criteria, but unofficially the site visitors get stuck on this older criteria. So they will do that math in their head, and our math isn't bad. You'd like to see it at, a quarter of all patients, but I think that's very, across the entire country for adults with cancer, it's on the order of 3 to 4%. And children used to be very high, 80, 90%. I think it's down below 50% in children as some therapies have become more standard. We have the other thing we're asked to do is to try to do our own studies or collaborate with other institutions that have their own ideas and not simply to port in industry sponsored trials. We'd like to do that with industry as we get more and more traction by being the people that actually help design the study for industry. We're the lead investigators, so we're not cutting out industry. We want industry to help. We want to collaborate with them, but we want to take more of a leading role. And also we are heavily subscribed to cooperative group trials, such as the Bone Marrow Transplant Consortium and a group called the Experimental Therapeutics Clinical Trials Network. This is a earlier phase clinical studies coming out of the University of Pittsburgh, and we have now joined that group as the only non-NCI designated center who's in this network now. And that's by showing we were interested, by showing we can accrue. We're actually helping their accrual numbers quite a bit. The other thing we've done is we are seeing patients. We're trying to do clinical trials where it's not what type of cancer that drives whether or not you get on the study, but what type of molecular lesion do you have? Do you have a RAF mutation in colon cancer, a RAF mutation in thyroid cancer? It's a RAF-specific trial. So we call these basket trials or tissue-agnostic, molecularly directed trials. These have been relatively easier to accrue to because it doesn't rely on having a cohort of patients with one particular cell of origin. And I think a lot of cancer therapy in the future is working on molecular basis of disease rather than where did the cell come from. We also, in our plans, we'd like to develop and align our clinical research more to the catchment area. We need to augment we know our catchment area, and I'll discuss this in a few more minutes, has a higher rate than the nation and the rest of Florida of smoking and tobacco-related illness. We have a lot of lung cancer in this area, so we need to augment those trials in that area. We need to develop more investigator-initiated trials like the type I mentioned of Dr. Sayer. We need to develop more of those studies based on our own science. And we'd like to show we can export some of these trials to other partners. We have one in small measure being done with Orlando Health. As the relationship between Gainesville and Jacksonville changes over the next couple of years, there may be more opportunities to export our clinical trials to Jacksonville and as well as other places. To summarize, we're now the clearinghouse for cancer interventional trials. We're aligned with the clinical research organization across campus. We have disease site groups, the lung group, the GU group, the GI group. Each one gets report cards of how they're doing on clinical trials. They get a green for doing well and red for not accruing. Everyone's really in the green. We're hitting on the order of 60 accruals per month across these studies, and we try to tailor our studies to the population we have. Not we'll have this trial for rare disease that patients will come flocking in. That just doesn't happen. It might happen in a bigger city with a bigger airport, but it's not happening here. So we have to tailor our studies to our population. The other thing we've done is increase the number of investigator-initiated trials, all towards doubling our activity. So those are two pillars. Any questions to this point? Any comments or questions? Okay. So the next pillar would be population sciences and the whole emerging big data initiatives. And part of this is wrapped into the notion of the NCI Cancer Center movement that our cancer research shouldn't be done in a vacuum in an ivory tower. We should think about how our research relates to the problems of our patients in our region and our co-citizens. So we're here in Alachua County, as you know, and we consider our catchment area a lot of these rural counties. If you were watching CNN last night, you got to know all about those counties, touching the little board, you know all about these counties. Okay, enough said. We know that this catchment area is nearly 2 million people in an area of the state that's quite large. It's about the size of the state of Connecticut, about 1/3 of the state, but it's rather spread out. We've got a low overall population density. It's a little denser in Alachua, but a lot of this is formerly considered rural. Our black population is 18% and Latino and Hispanic about 8%. Notice the rurality, 20% versus 4% of the rest of Florida and 15% across the United States. So a lot of rural individuals. There's a higher poverty rate than the rest of the country in the state. There's less persons with greater than a bachelor's degree, or as seen here, than the rest of the country in the state. And there's an older population, particularly in Marion County. There's also an increased rate of obesity and adult smoking. So we have a real setup for a lot of risk factors for cancer incidence and cancer mortality. As such, our cancer incidence rate is pretty high, particularly in Marion County. This red dot is because it's an interesting thing. There's a paper in JAMA saying that they're killing people in Union County, Florida. That's because all the prisoners go to the prison hospital there, and if they die of cancer, they're considered a death in Union County, even though they might have lived all their life in Broward County. They're dying here of cancer, so Union County is just killing them off. So it's a statistical fluke. I saw this, and I had Dr. Shankman and colleagues write a letter to the editor of JAMA, and they actually published the letter. But the authors of the article were not impressed. The other thing is I did a little thing. I went to Google Maps and I found this mortality map for cancer. And then I went to Google Maps and I saw, here's a place in Texas where they're killing people left and right. But then I take a look. There's a prison there also. So it's interesting how there's statistics and damn lies or whatever. But anyway, that's a little anecdote. I digress. But here's the real problem here is that the mortality is terrible in this area compared to the rest of the state. And I mean, we'll do what we can, but frankly, some of this is rurality, lack of transport, lack of resources, lack of Medicaid expansion. The system is designed to give the results to which it's supposed to give. or something like that. But we have to meet that challenge anyway. What can we do to further understand, guide future policies, guide future research to understand why these people are doing so poorly with cancer? We know they show up with late-stage diagnosis. We engaged a community advisory board and got a bunch of people together telling us how, people don't necessarily want to be screened because they don't want to hear bad news. But we have to fight that. We have to do some informational interventions to try to get better communication to our population, overcome this distance. We also know the catchment area is rich in these tumors, lung cancer, the commonest, and we see it in our clinics. Breast cancer, common, we see it in our clinics. We see a disproportionate amount of blood and bone marrow cancer compared to the catchment area, a little bit more because we're a center for bone marrow transplantation and blood malignancies. But we are seeing the cancers relevant to the catchment area, and we need to augment our research in those types of cancers. We've done a survey of the catchment area by random digit dialing. We find that people generally like to seek health information. They use the internet, but we find that people with less education, blacks and Hispanics and lower income people, perhaps not so surprising, or more at risk and don't have as much information. And low-income individuals who are African American are at great risk. We also find that the tobacco use is more in the rural white population. We have some disturbing things. 60% of people think everything causes cancer, and they don't. 2/3 don't know what to do, and 53% don't believe that their lifestyle has anything to do with cancer. So we have some information deficits that we need to overcome. We see opportunities for intervention here. And we also find that we don't have enough women engaging in our clinical research, and we were trying to understand why women offered clinical trials are not choosing to sign up. So we have some more work to do. We have issues to address in the catchment area that we're planning to address. Towards doing this, we're going to start a few projects in the next 120 days. We had a meeting about this at 10 a.m. We discussed it with our executive board meeting. We're going to commission some studies and try to do some demonstration projects to better engage our far-flung population with ideas of taking control of cancer risk and also taking control of the cancer diagnosis. Once people get a diagnosis, there's a lot of wayfinding. There's a lot of financial issues that they need to deal with, and we're going to try to see how we can study that and potentially help. And working with IFAS, they have CDC grants to try to prevent cancer and other disorders by preventing pesticide exposure in our large agricultural worker base in North Central Florida. We want to partner with them to help with that. We have a community advisory board with people from local, as well as we have people come from Cedar Key. People came from Tallahassee to come to our advisory board to engage them and to understand how we can better serve their communities. We've asked for priorities, that we're collating those priorities and planning to follow up and actualize some of these in early 2019. We've also been working in terms of state policy. Dr. Shankman's been quite involved with Florida Medicaid. Chris Kogel has helped change the definition of leukemia in the cancer database of Florida, which has a very extensive registry for cancer cases, trying to bring in more of the diagnoses of pre-leukemia, myelodysplasia, myeloproliferative neoplasms, unexplained anemias, trying to get them nosologically, means disease classification, more into the leukemia basket. And when you do that, you actually see that this area of the state, particularly with our aging population, has a pretty high level of blood malignancies and is a pretty prominent set of tumors. This just indicates some of our linkages. In our population sciences group, we have, again, $6 million per year of support, with a lot of it being other peer-reviewed, including the Pragmatic Clinical Trials Research Institute, part of the Affordable Care Act, PCORI, where you actually try to study in real life situations the outcomes of different cancer interventions and other interventions. And we have, again, a lot of collaborations and cancer-relevant publications. Amongst the things that, as a hallmark of this program, is a focus on cancer communications including this.
Hi, I'm Dr. Alex. I'm a virtual healthcare provider with the University of Florida Health System Network. I'm speaking with you today because you've been selected to try out a new system where patients have an initial appointment with me before following up with your regular doctor. I work with your doctor.
So Alex is our virtual healthcare. Alex can be sort of like, who's got Bitmoji on their phone? Yeah, okay. Yeah, so Alex is sort of like Bitmoji. You can make, I have a Bitmoji. I have a hat usually, but you can make Alex look like a Bitmoji. You can make Alex look infinitely customizable to try to project a healthcare communication message. Some individuals might respond to people who sound or look more like they do, and that's an experiment. That's a hypothesis to be tested. Can this informational intervention work to get people into the healthcare system, into taking some charge of their health? So this is an informational intervention using virtual human beings. And this is an NIH-funded grant to do this, representing a lot of disciplines, including engineers who help customize these virtual persons.
Hi.
Okay, hi. Now, another hallmark of this program is the cancer disparities focus, championed by Dr. Odedna from the College of Pharmacy and Dr. Wilkie from the College of Nursing, also highlighting two different colleges. We're not College of Medicine. Don't make no mistake. We're not College of Engineering. We're University of Florida wide. Dr. Odedna, working with Dr. Okonieff, my predecessor in this position, started a minority training and engagement program trying to bring underrepresented individuals into the cancer research field. This has now graduated into a U54 collaborative grant with two purposes. One, to study the biologic and social and economic and other determinants of disparities in cancer outcomes between people, whites and non-Hispanic, non-white Hispanics and blacks and other individuals, so minority populations, and to bring people who from various minority groups into the cancer research education pipeline. So it's both education and training as well as a research program. And they just got this grant from NIH, which is a collaboration between UF. They have a component. We have a component. Florida A&M, a historically black university, and the University of Southern California. So this is one of the very few centers in the country, and this is something they just opened up last week. To summarize this and our plans, we need to continue to build our population science programs. We're going to be avidly looking for a cancer epidemiologist. Someone interested in exposures and rural health would be very well aligned with us. We'd like to further develop faculty involved in studying implementation of real clinical translational findings into the clinic and the uptake of such technologies and practices, health equity communications, and the study of the biology of cancer symptoms. These are all things in our population science program. So we've defined our catchment area. We've developed research programs. We have the U54. We've invested in other aspects of this program, such as electronic mobile health, the One Florida Data Trust, which takes 14 million Floridians' medical records, puts them into an anonymized database that can be queried. You can cross-reference who's used a checkpoint inhibitor in Orlando over the past 2 years. And we can look at those trends, for example, in the usage of new technologies and who's getting them and who's not, based upon these electronic records. We've convened an advisory board, and we've actually we've established an Office of Community Outreach and Engagement led by a medical anthropologist, Dr. Sarah Zurich, who's been studying communities with different healthcare needs as part of her entire professional life. Our last pillar is workforce development, and this means this doesn't mean training people to become medical oncologists or hematologists or radiation oncologists. It's a matter of training people who could be in those fields, but to train people across the spectrum to engage in research. It means the whole spectrum, from pre-collegiate, getting people in high school into our laboratories, people in the vast pool of undergraduates we have here, our graduate programs, including the cancer biology program, our postdoctoral programs, which we're continuing to augment, and junior faculty, including basic researchers, translational population researchers, and laboratory-based researchers. So all kinds of junior faculty. So one of the things we try to do to engage the community is to augment this series. Of course, there's free lunch too, which helps. But we think we've brought and we continually need your suggestions of who to bring, but we try to bring engaging speakers from around the country to give opportunities for them to learn more about us, learn more about them, form new collaborations, put UF on the map. When I came here 3 years ago, this is like one of the best kept secrets in the country, that there's great stuff going on here. And what I felt we had to do is get people in here to learn more about it. And people come away, of course they get a free baseball cap and autographed plaque, but they also get a great visit with our faculty, with our trainees, to understand what we're doing. So we try to buff these things. We just had Research Day. Many of you were there. We had a great attendance, and we think that's another thing to do to engage the trainees and engage people here, and other special programs as well. Here's some pictures from Research Day. We had almost 80 posters. We had 9 poster winners who got travel awards for their work. We also had our 4 pre-doctoral award winners. Anyone who's finished their qualifier exam and has perhaps a year or 2 left in their thesis work can apply for this competitive program to get support for them in their laboratories for their thesis research. And we had, of course, our keynote speaker, Dr. Dimitrovsky from the Frederick National Laboratory in Bethesda. And so this is, again, another forum for people to get exposure to Dr. Dimitrovsky. He met with all the award winners over lunch, and for them to learn more about us. We also have an innovative early stage investigator program. November 16th, next week, we have 10 K99 or other K award holders, people who have grants to transition to full-time faculty, have been invited to campus to give a seminar, to visit with faculty, to visit with the groups in a group kind of recruitment. So 2 things here. They learn more about UF. It gets the word out. We form new collaborations. Everyone's on an email list server. Those people are learning from each other based on their connection through us. And we recruit people from this pool. We had last year 9 people came in. 2 formally applied for positions. We recruited 1. So this is a way for us to bring great people here, really, really outstanding emerging investigators, and see which one of those this is a good match for. And this was last year's class, and this is Dr. Maliki Kaligan, who's in the Department of Biochemistry. Her lab's in ARB, and she's off and running. Okay, we'll go here. The other thing that Dr. Seaman and working with our staff member Wendy Milazzo championed, very innovative program, is teaching science teachers. How do we engage people at the earliest pipeline for getting involved in basic STEM research and cancer research, is to get the science teachers excited about what's going on in the field. We had about 36 science teachers come last summer, and that was after we came up with the idea only I think in April. And we had 2 months lead time. We got 30 science teachers. We're going to start with an earlier request for applicants or whatever. We think we'll double the attendance this year, I believe. And we got really good feedback, and we had a good engagement of our faculty teaching lectures here, and also having some of the graduate students involved and other postdoc fellows involved in the training. It's another way to actually have our trainees get involved in this. I will also say that through some of our programs, such as our program of supervising undergraduates, we get postdoctoral fellows involved in learning how to mentor. So we're having a continuous set of cycles of research, training, engagement, including teaching the teachers and teaching the postdocs how to train the graduate students and so forth. So a virtuous circle. Biostatistics 101, Dr. Lee initiated this course, and as I mentioned, 44 people just got their certificate in biostatistics. This course will be offered once a year, twice a year? Once is enough? Okay. So once a year, it'll be every fall for new classes. And again, we mentioned bioinformatics will be coming up as well. The other thing we're just starting is a new idea. We're starting a cancer research policy internship. We're going to offer to graduate or professional students a 16-week paid internship working in Washington, D.C. With our elected officials in their congressional staff offices to have a project on healthcare delivery, patient advocacy, could be on research, these other topics here. So it's going to be a very unique program that basically a number of us were on Capitol Hill advocating for cancer research. We talked to our legislative affairs associate contact in Washington, D.C., who works for the university. We came up with this idea while walking the halls between Congress. And if any of you ever want to advocate for cancer research, I really suggested lobbying Congress is like an experience you've never had before. The panoply of people, different advocacy groups walking the halls, exercising their constitutional right to petition Congress. It's really something to behold. And you go in and you meet with these very, very bright staff people from the congressional offices, and we want to embed some of our people in those offices to help influence the research and training agenda. We're also going to have a program for postbacks, those people who may be recent UF or other college grads that want to get involved in clinical research, to spend a year in a paid internship in our clinical research office to learn the ways and means of clinical research. And this is another, I'd say it's both, they're doing work and they're also learning and engaging in cancer research. Dr. Odena has championed underrepresented minority education in a series of programs, including the Minority Training Center, now the U54, and an R25 grant she has, a special training grant that she has for engaging people from, in her case, engaging a lot of people from historically black universities as listed here before. So in summary, we've really tried to, what we need to further do is I want to reach out more to our clinical trainees. They are not, we need to reach out to our clinical trainees and get them more involved in cancer research. We want to expand the Science Teachers Conference. Dr. Siemens is working with us to try to get an institutional training grant from the ACS, an institutional training grants from the NIH for cancer research. And we're going to be working on that in the coming year. We do partner with the CTSI. We have a CTSI and Cancer Center supported, cancer-focused K grants and T grants. And what I'd like to do is further help our, we're trying to help the numeracy of our program members through the biostatistics course, now an omics and biomedical informatics courses. And one thing I've been thinking about is getting more of our chemists and engineers involved in creating a boot camp for cancer biology for the physical scientists. That's something we did when I was at Northwestern. We did some of these sessions, and the physical scientists getting engaged in cancer research found it quite useful. So to summarize, I think we've created a lot of interesting programs and unique opportunities. We've been recruiting early stage investigators and really try to hit the minority training and trying to increase our biostatistics and numeracy literacy program. To summarize, I think we've come a long way. The University of Florida Cancer Center, the campus, looks quite different now. We look quite different now. Here's our timeline. We it's now 190 days until submission of our NCI cancer grant on May 16, 2019. Here's how it works. On November 26, a group of associate directors of the center and myself will be going and presenting a lot of what you see here to the NCI program office. That's sort of our official pre-submission inquiry. You cannot send a grant of more than $499,999 to the NIH without getting pre-authorization. This is a $1.4 million per year grant. We need authorization from the NIH to submit the grant. And this authorization comes in the form of a site visit, a reverse site visit to the program office to explain what our program's about, what we're trying to do, what our catchment area is, how we're meeting the challenges, and getting their feedback and getting questions about the mechanics of the grant answered. Our grant submission, we have, I'd say, about a quarter of the grant is in close to final form, and the other 3/4 is in development, and it'll be in various stages of development, and we will have it ready to hit the button on May 16th. We get site visited. This is one of the few grant mechanisms in the entire NIH portfolio that requires a site visit. There used to be program project site visits. Those went away in about year 2001 or so. This is I don't think CTSIs are not site visited. These are site visited. We will get visited sometime a year from now, probably 11 months from now, more likely, by a panel of cancer researchers from other NCI designated cancer centers. They could be basic, they could be clinical, they could be translational, they could be other administrators. I've done 4 of these site visits since I came here. Dr. Wingard's done 3, and Dr. Rennie has done 1. So we have an idea of what the drill is and how people will ask us questions of our presentations. We will have also introductory talks by Dr. Nelson, should he remain Health Sciences President, and Dr. Fox to indicate the university's endorsement of this. We will get a score sometime 2 to 3 weeks, I believe, after the site visit, initial score. That score can get changed because it gets integrated into a parent committee where a subset of members of the site visit team are in a big room where they discuss all the programs that they've visited for that quarter. That probably there are 3 submission times per year, just like NIH grants. So this committee meets 3 times a year. So they'll come and give us an integrated score that we would get with our summary statement in about, we'll get our summary statement in October, November. We'll get our final summary statement with the score in the end of 2019. This goes to council in January 2020, and the earliest time for an award letter would be April 2020, and the earliest start date would be May 2020. The NCI is committed to funding new cancer centers. They believe they'll fund 1 per year. We don't know any other center going in our cycle. Miami just submitted their grant on September 25th. They get site visited this January, and if they might get funded, I guess by June or July, something like that. So they might get funded this year. But the other thing is, once we get this, one reason we're going to NIH is that we have to get the Cancer Center office on our side, tell them what we're doing, because that $1.4 million a year comes out of something else. You know, this is new money given out externally. Could be a few less R01s, could be a few less intramural programs. You have to get the NCI director on board. You have to get the other associate directors of the NCI on board to redirect money to a new extramural cancer center, committing, $7 million over 5 years or so to the center. $7 million less from their what else they can spend on. So we have to get their support. So with that, that's my update of where we are at the Cancer Center. We have a few minutes. If there's any questions, I could answer for you. Thanks for attending. Yes.
At the last Cancer Population Sciences meeting, Dr. Tom George gave a very quick overview of some of the things that we're looking for. And he basically said that there'd be additional support for grants from the Cancer Center for both for clinical trial support and for statistics support. something about there's a dedicated person, at least for population sciences, to help with the IRB process and such.
We have that. We have a statistician assigned to your program. She's sitting right behind you in terms of statistics. Dr. Lee is the statistician assigned to population science. If you have problems with IRB submissions, Allison, who should Walter talk to?
So I think what you're referring to is the new CPS Navigator that we're just moving into that position in a week. And so we'll have the generic email address where folks can email for support with navigating through that whole startup process, DSGs if it's involved with that, SRMC as we talked about. So we can help you with that process for sure.
So the major support is for interventional trials, which is the priority that the NCI has developed. But IRB support is to even non-interventional cancer-relevant studies. So that's Allison.
Yes, Allison.
Oh, wait. The IRB support is for non-interventional and interventional, but the clinical trial support is focusing on interventional because we have limited resources and we're focusing on what the NCI values the most and we will get reviewed on is interventional trials.
Any other questions or comments? Well, let's get to work.